Hey there, this is Walt Lubbers again. So this is another part of our ED ECMO / best resuscitation morning on EMS Grand Rounds, and unfortunately this was another lecture that, while given and was beautiful in its entirety, did not get recorded, unfortunately, due to technical difficulties. So I wanted to give this to you. This isn't as probably grand as it was before, and the formatting is a little different, but hopefully you'll enjoy it. But this is, what do you actually do from the pre-hospital side if you think you're going to bring a patient into the emergency department that may be a candidate for eCPR or ED ECMO? Well, number one, of course, you have to have the right person to do so. And this therapy won't work for everybody. I mean, you can certainly put people on ECMO, but that doesn't mean that they're going to survive or their brain's going to survive or that it will benefit them at all. So we want to be picking the right people, the right folks for it. Here are the overall criteria, and we'll just kind of hit each one of those one at a time. So you want somebody that's in persistent VF or VT, that started in VF or VT when you got there, or somebody applied an AED and it gave them a shock. That person has some potential for saving. Those are folks, if you look at it, we're really just selecting folks that are most likely to survive anyway, but they're also the best ones that are most likely to benefit from this therapy. The thing that we would hate the most is to take up a very expensive therapy, both in terms of money and in terms of manpower and availability for other people. We would hate to take that up with somebody that is not likely to survive. So we're looking at folks that are persistent VF or VT, that started in VF or VT, and despite getting shocked, we said initially 3 or 4 times. It'll probably be 4 by the time you get really get the call made and get it all confirmed and get the person loaded in the ambulance. 4 defibrillation attempts and have not gotten ROSC with it and had an antiarrhythmic, either 300 milligrams of amiodarone or some lidocaine, depending on your local protocol. So those folks would be the guys that at least we would look at as initial criteria for it. They have to be relatively young. And again, it's not that we don't like old people. It's just that older people are less likely to survive. And certainly it doesn't mean that not everybody who's over 65, that you should just stop coding them. But the folks that are more likely to survive are the ones that are younger and can probably tolerate the arrest a little bit better as well. These folks have to have a short downtime before they got CPR, so less than 5 minutes. If you're in a place that has good dispatcher-initiated CPR, then this might be a possibility for a lot of people. If you're in a place that doesn't have that and you're just kind of, Wild Westing it, then that might not happen for a lot of folks, and that may take a lot of folks out of the running. And it's not so much that we don't want to offer it to these guys. It's, again, if you go more than 5 minutes without getting bystander CPR, the chance that your brain is going to come back without significant damage is relatively low. So we're sticking with that less than 5 minutes prior to getting CPR, and about 5 minutes. Obviously, no one is going to put a stopwatch to it or anything like that. And it can be bystanders, or it could be professional rescuers or fire first response or whoever it is. But somebody needs to be pushing on this guy's chest within 5 minutes of them collapsing. One of the other things that's important is short pre-hospital time. So from the time that someone calls 911 about this patient, from the time they arrest, if you happen to be on the phone with 911, to the time that they arrive at UK, really needs to be under 60 minutes. And again, it's not that we don't like people or that we want to exclude anybody from it just because you live far out and that doesn't really seem fair. It's strictly pragmatic. Folks that are going to benefit from this, folks that are going to come back, folks that are going to survive, are those that get put on ECMO shortly after arrival, and that arrival usually has to happen under 60 minutes. So it's no offense to anybody else out there, and we wish we could just say bring them on over and we'll put them on, it'll benefit everybody. But if you've been getting an hour of CPR, your chance of survival, of neurologically intact survival, is relatively slim despite anything that we would do otherwise. So again, we're putting it at the time, as close as we can from the time that they go down to the time that they get to UK Chandler. We want that less than 60 minutes. Now, of course, if the guy, if this is a rearrest, if the person got pulses back and then 20 minutes into the call as you were in the ambulance, they lost pulses again, it's a little bit of a different story. But for the most part, if it's just an ongoing arrest, we'll say if they don't get here within 60 minutes, they're probably not a good candidate for ECPR. One other thing that we were sort of toying with was whether or not mechanical chest compressions should be mandatory and that they should be taken out of consideration if they didn't get mechanical chest compressions. And I am in favor of doing so. Again, not because I really care all that much about whether or not you personally got got mechanical chest compressions, but because I think it is dangerous and I think it is ineffective to try to do CPR in the back of a moving ambulance or when you pick somebody up or on a stretcher walking through the hallway. And anybody that has watched somebody try to do that sidearm CPR as you're walking into the emergency department, you're pretty sure that that person's not actually getting perfused. And the pauses that we have are minutes long. We don't realize how long we're actually not doing effective CPR. But it's anywhere from just the move from the ambulance to the bed itself will result in an interruption of 3 to 5 minutes of decent chest compressions for almost anybody. Simply moving out of the ambulance is going to take you off the chest for at least a minute and a half, practically speaking. And that's not something that I'm just making up off the top of my head. That's really, if you observe somebody, it takes about a minute and a half before you can do effective CPR for any length of time again. So if you have a mechanical chest compression device on somebody, then, okay, great. We've got that problem taken care of. They can get good chest compressions, and it'll just keep on going, whether they're on a backboard or whether they're being pushed down the hall or coming out of the ambulance or however you want it. Just set it and forget it, and that's great. What do you actually do with that person once you identify that that they're somebody that may be an ECPR candidate? Well, number one, you've got to do great care on scene. And some of that is dispatch CPR instructions so that the people that are on scene first, the bystanders, can actually do the greatest care that they can. Telling folks to get an AED and then how to put on that AED. This goes back to dispatch. And dispatching all units is not just be advised there's a patient needs care found down. Like, you don't know what that is, but if we have a way to dispatch out at kind of if you look at the EMD thing, an echo level priority, so that we can get somebody on scene doing good CPR, somebody that knows at least a little bit about what they're doing on scene, that can start doing chest compressions and do BLS stuff as early as possible. That's the stuff we've got to do first. Once you're on scene, we need to do immediate continuous chest compressions. We need to be using an AED if you're a BLS or first responder, and immediately driving towards getting shocks in if you're an ALS responder, putting the person on the monitor. If you're going to give epi, you should consider probably giving it IO unless you can get an IV relatively quickly, like on the first shot. Epi should probably get given every, say, 5 minutes or so. Amiodarone should definitely be given after the second shock. If you wanted to, in the first couple of minutes of your resuscitation, back it down to every 3 minutes on the epi, that's great, but amio should be given after the second shock. And don't leave that as something like, what else could we do? Oh, we could give amio. No, that's not really the way it's written. If you give a couple of shocks and nothing's coming back, then think about reaching for the antiarrhythmic relatively quickly. Let's talk airway management. This is a big deal, and there's a fair amount of controversy about, number one, should we be doing any kind of advanced airway management, or should we just be doing BVM for folks in cardiac arrest in the pre-hospital setting? Certainly, probably the worst thing that you could do would be to shove an ET tube down the guy's esophagus, not realize it, and say that you have a successful advanced airway and just insufflate his stomach the entire time. That's not only not going to help, it's definitely going to hurt, and you'll essentially assassinate that person and take away any chance of survival that they had. Putting a tube down the esophagus and not realizing it immediately is going to be a fatal move for this guy. So endotracheal intubation, while I think there is a role for it, really should probably take a back seat to BVM. You can use an iGel, you can use a King airway. The data is not as solid on that one as much as it is using a BVM, Of course, if crew resource management dictates that I've only got so many hands and I got to get one hand free because I can't effectively bag and so I need to do something, then by all means, put in a king, put in an iGel, do something, but manage this guy's airway. If you're going to put in an ET tube, then make absolutely sure that it is in the right spot, because otherwise this person is dead. And there's nothing that anybody, including God himself, is going to be able to do about it if you put the tube in the wrong spot and don't recognize it. So every one of these guys, no matter what it is, should have end-tidal CO2 either in between the mask and the bag, or at the top of the king or the iGel, or at the top of the ET tube. And it's got to show a waveform. Otherwise, the tube or the device is in the wrong spot and you got to fix it. That's an absolute must. If you're going to do anything other than BVM, you've got to manage the airway appropriately. And you can't pause for a long time to get the tube, and the tube's got to be in the right spot. Obviously, I feel sort of strongly about that, so sorry to spend that much time talking about it, but it needed to be said. By the way, we should do great care on scene until we recognize that it's time to go. So after we do that fourth shock and give that dose of amiodarone after the second, in between second and third, closer to the third probably, once we establish that it's time to go, then we need to go. And we need to not worry about delaying for other stuff. You don't have to do a pulse check. Nothing says you have to do a pulse check every 2 minutes. If you just want to wait, and most of us do, I think, but if you just want to wait till you're completely secured in the ambulance and somebody else is running around to the front before you do your next pulse check so that you can get underway, that's cool. If the goal is to get somebody to the hospital so that they can get on ECMO support, then make that the goal. And yeah, do great chest compressions, do great BLS skills in the meantime. But when it's time to go, we got to go. Identify these folks early if you can. And what I mean there is that if you recognize that this person is an eCPR candidate, or if you see that the person is just young and in VF/VT and you're not sure if they are or not, call us early. Call dispatch 859-323-6215 and ask, and they'll have the criteria in front of them. And they should be able to give you an answer about whether or not this person sounds like an eCPR candidate or not. But if they are, let us know before you leave the scene, or even while you're standing on scene, looking at the person saying, okay, now I think is the time that we need to go. Give us a call early, because it's going to take us a few minutes to haul all these people down to the emergency department and get everybody together. So as much early warning as you can give us, that's great. Now, again, I'm not a big fan of making people memorize hospital protocols or hospital activation criteria or all that kind of stuff. But if you definitely specifically know that this is the reason you're bringing someone to UK, make sure you say that so that it's 100% beat you over the head clear that that is the reason the person's coming here, and we can be ready for it. Or we can evaluate it and maybe give you a thought or maybe a different disposition if it sounds like the person's not actually a candidate, or clear that stuff up. So definitely notify communications early. Once you do that fourth defib, if they're still there or if they're still in VF or VT and they're a potential candidate, then let us know early. Once you get underway, once you've given that fourth or fifth shock, there's probably not a great reason to continue going on doing the same stuff you're doing, because theoretically you've already got the airway managed. Theoretically, you've given like 3 doses of epi, and their blood pressure should be adequate if that's the case. Unless something changes, there's really not a great reason to just defibrillate this person again. If you just keep doing it, there is, some folks say there's not any evidence of damage. There almost certainly is some myocardial stunning that goes on. And there's probably not a lot of benefit to just keep doing the same thing that you're doing with no essential change. Now, if you've gotten, say, if you thought hypovolemia was the problem for some reason and you, say, got a liter of fluid into the person, you want to see if that makes a difference. Okay, I'll buy that. But just because it's in the algorithm doesn't necessarily mean it's the best thing for the patient. So again, if ECMO support is the goal, don't worry about defibrillating every 2 minutes. Maybe space it out to every 4, or maybe don't defibrillate at all. Continue to check, maybe do a pulse check or a rhythm check every now and then. But if the goal is to get somebody on eCPR, then focus on getting them on eCPR, because we've already established that they're probably not going to shock out VF or VT. At the same time, when I mentioned epi before, that's the first couple of initial doses of epi. After you've had, say, 3 doses or so, if the blood pressure hasn't gotten up sufficiently that you're able to back perfuse the coronaries appropriately, then the chance that doing a whole bunch more is somehow going to help. Like I've already got 5 milligrams of epi on board. What's the chance that a sixth is really going to be that beneficial? That's pretty small. And one of the other things that happens is the way epi works in cardiac arrest is that it is primarily an alpha agonist, and so you get all this peripheral squeeze, and your vasculature becomes small so that you can perfuse the brain and raise the blood pressure and backfill the coronaries and get better perfusion and maybe get ROS. That's the way that epi is supposed to work. However, it doesn't just vasoconstrict out in your periphery and in your arms and your legs and in your gut. It does so in your brain as well. And vasospasm in the brain, under any other name, would be called a stroke. But when we give a whole bunch of epi and cause it in cardiac arrest, we call it standard care. So I would challenge you to lighten up on the epi unless you've got a reason to be given it every 3 minutes. Back it out to, at least the outer limits of recommendation, so 5 or something like that. Once again, you establish that the person needs to go on ECPR or is a likely candidate for it, then just go ahead and back off and let their brain get a little bit of the blood flow that hopefully we're able to perfuse. Hopefully that we're able to send up to it with our good mechanical CPR or our excellent hands-on CPR. Overall, don't forget that, we're driving to the hospital, but you got to continue to give the best care you can en route. And it's not okay to slack off on any of this stuff because we're going there. If you don't do great care, the person's still not going to survive. And you have a potential to really make an impact on this person based on what you do. If you can sustain them until they can get on ECMO, and then we can keep them sustained on ECMO until they can get their coronary opened up, that's a life-saving thing for somebody. Or until they can get their pericardial effusion drained or whatever is going on, that may be life-saving for this person. So do the absolute best care that you can en route. If you have any questions about any of that, I like to give out my cell phone number to most people, and I generally answer it. This is a really important topic, and it's something that if you have any questions about, please don't hesitate to ask. We'll be happy to go out and help set up simulations at your agency. If you're wondering if maybe you can get to the hospital in time, like, I think I'm right on the edge. I wonder if my crews could pick up a patient and take them to UK and make it in under 60 minutes. Let's find out. Let's go take a dummy outside, plop him in the middle of the field, and then we'll call 911 and see what our times are, but also see what our chest compression fraction is and how well we manage the airway, and did we use end-tidal CO2 and everything else. So we'd be happy to go out and help put on some simulations for you if that's something that you're interested in. But any questions or logistical problems otherwise, please don't hesitate to give me a call if you want to personally, 859-547-2025. Or call UK Dispatch if you're out in the field, 859-323-6215, and we'll get those questions answered. Otherwise, stay safe, and we'll see you around the ED.